Hello everyone. Very good evening. This is Dr. Sangeeta Chaudhary once again. I welcome everybody to this live session. My second live session on this channel. I hope you enjoyed the last session and I hope that you'll enjoy this session also. So in the last class, I had discussed about stable angina. Basically, I am discussing on coronary artery disease. Yes, class, I discussed about stable angina. And in today's class, I'm going to talk about non-ST elevated acute coronary syndrome. That is NSTE-ACS. Non-ST elevated acute coronary syndrome. This NSTE-ACS, it includes two things. It includes what we know as NSTEMI. NSTEMI means non-ST elevated myocardial infarction, okay? And the other one is unstable angina. So today we're going to learn about unstable angina and NSTEMI. These are very important topics, not only from your exam point of view, but for your clinical practice as well. And I'm going to discuss about various things which will help you even in your competitive exams also for your MCQ purpose. So I hope you will follow the class and you like the class. So coming to the ischemic heart disease, we know that ischemic heart disease can be divided into stable angina and acute coronary syndrome. So stable angina, we already know about it. Acute coronary syndrome, it includes two things. It includes NSTE-ACS, which are today's topic of discussion, that is non-ST elevated acute coronary syndrome, and the other one is acute STEMI, that is ST elevated myocardial infarction. I'm going to talk about STEMI in my next session, in the next live session. So if we talk about the pathophysiology of NSTE-ACS, that is NSTEMI as well as unstable angina, the main pathophysiology is the imbalance between the myocardial oxygen supply and demand that results from coronary arterial thrombosis. In word, when there is coronary artery thrombosis, the blood supply to the myocardium will be more so when the demand increases. Okay, the oxygen supply will not be sufficient. The blood supply will not the demand of the myocardium. That is why patient develops acute coronary syndrome. So the main cause of coronary thrombosis can be of three things: plaque fissure with inflammation, okay, plaque fissure without inflammation, plaque erosion. I'm going to talk about these plaques. So in this picture, you can see there is a ruptured plaque. Okay, there is something known as vulnerable plaque. Vulnerable plaque. What does it mean? Vulnerable plaque means they are very prone or very vulnerable to rupture, resulting in coronary thrombosis, thereby leading to occlusion of the coronary lumen, leading to myocardial infarction. Vulnerable plaque, two characteristics, main characteristics. It will have a lipid-rich core. Okay, plus it will have a very thin fibrous cap. So these are the two characteristics of a vulnerable plaque. So here we can see a plaque, it was vulnerable and it has ruptured. Okay, so this is the lipid core, the yellow thing is the lipid core, this was the thin fibrous cap. Okay, the plaque has ruptured, and because of plaque rupture, what happens when rupture of the plaque? The platelet will come into action, there will be activation of platelets, then there will be aggregation of platelets, and the coagulation cascade also will set in, ultimately resulting in formation of thrombus. Take 1 minute break. So I was talking about a ruptured plaque. Okay, there is something known as vulnerable plaque. Okay, vulnerable plaque means the plaque which is very much prone for rupture. And once a plaque ruptures, there will be thrombosis. Okay? So vulnerable plaque has two characteristics. There will be a lipid-rich core, okay, plus there will be a thin fibrous cap. Lipid-rich core plus thin fibrous cap results in a vulnerable plaque. So in this picture, we can see a plaque which is ruptured. It was vulnerable because we can see that there is a high lipid-rich core and there is a fibrous cap. It has ruptured, and because of the rupture, there is formation of a thrombus. When a plaque ruptures, there will be activation of the platelets, and it will be followed by aggregation of platelets. There will be, the coagulation cascade also will set in. And once the coagulation cascade set in, there will be formation of fibrin, and ultimately there will be a formation of thrombus. If the thrombus occludes most of the lumen of the coronary artery, then there will be myocardial infarction. It's about a ruptured plaque which has a thin fibrous cap, collagen pore fibrous cap. It has large lipid core just now, and there is usually a fibrin-rich thrombus. Now, I was talking about plaque erosion. Not only the plaque rupture, even the plaque erosion can also result in coronary thrombosis. So, this is an eroded plaque. Here you can see an eroded plaque. Eroded plaque, they usually do not have any lipid-rich core. Even if it is there, it will be very minimal amount of lipid. Okay, it will be rich in neutrophils and nets, and it contains very high amount of smooth muscle cell. Okay, and the thrombus is platelet rich. So this is about eroded plaque and a ruptured plaque and how it causes thrombosis. So whenever there is a fixed plaque, if the plaque is fixed, atherosclerotic plaque, it will lead to stable angina. Okay, if there is a plaque rupture and platelet aggregation, it will lead to unstable plaque leading to unstable angina. And if there is thrombus formation, where the thrombus is not occluding the whole of the lumen, then it will cause non-ST elevated myocardial infarction. And if the thrombus occludes whole of the lumen, it will cause ST segment elevated myocardial infarction, that is STEMI. What is the main difference between unstable angina and STEMI and STEMI? Okay. Unstable angina, it is because of a non-occlusive thrombus. Just now we have seen in the pathophysiology, the thrombus will be non-occlusive for both unstable angina and STEMI. But for STEMI, the thrombus will completely occlude the lumen of the epicardial coronary artery. Complete occlusion, STEMI. Complete occlusion, unstable angina or NSTEMI. ECG changes, if we talk about unstable angina, ECG changes are non-specific. Whereas in case of NSTEMI, there is usually ST depression plus there is T inversion. Okay, T inversion may or may not be there, but ST depression is there in ECG. In case of STEMI, as the name suggests, there will be ST elevation or there will be a new onset LBBB. LBBB stands for left bundle branch block. There will be sign of new onset LBBB or else there will be ST elevation. Okay, this is the ECG picture of these three types of acute coronary syndrome. If we talk about cardiac enzyme, very importantly, the cardiac enzyme will be normal in case of unstable angina. Okay, but in case of NSTEMI, there will be elevation of the cardiac enzyme, as well as in STEMI also there will be elevation of cardiac enzymes. Cardiac enzymes, why they are getting elevated? Cardiac enzymes or cardiac biomarkers, they present myocardial necrosis. So whenever there is myocardial necrosis, the troponins will come into the blood and there will be elevated level of troponin in the blood. So if there is myocardial necrosis like in NSTEMI, we will get elevated troponin, that is raised cardiac biomarker. And if there is no necrosis, there will be no elevation in the cardiac biomarker. for example, in case of unstable angina. But I just want to mention that these days the incidence of unstable angina is reducing and the incidence of NSTEMI is increasing. Why so? Because these days we have an investigation highly sensitive. Because of the highly sensitive troponin, many of the unstable angina cases uh, are diagnosed as NSTEMI because it is so sensitive, minimal amount of myocardial nephropathy. That is why the incidence of unstable angina is coming down and the incidence of NSTEMI is going up. Talking about the risk factors for CAD. Okay. The risk factors can be modifiable. We already know, and I have discussed also already. Risk factors can be modifiable or non-modifiable. So, very important risk factor is smoking. Smoking, it causes endothelial dysfunction, causes destabilization of the atheromatous plaque, it causes vasospasm. So many things cause smoking, diabetes mellitus with uncontrolled blood sugar, dyslipidemia, hypertension with uncontrolled blood pressure, obesity, okay, physical inactivity, cocaine abuse. These are the modifiable risk factors. Among the non-modifiable risk factors are age, an important factor for coronary artery disease. Okay, male sex, male, they are more prone to develop CAD. Positive family history, especially in first degree relative, if there is history of premature coronary artery disease, then the patient also will have an increased risk of CAD. Ethnicity, certain groups of people, for example, blacks or whites, they are more prone to develop CAD than the other ethnic group. Coming to the clinical feature, the most important thing, how how you suspect that the patient may be having may be presenting with acute coronary syndrome. Okay, the patient will have severe chest pain, severe chest discomfort, and the patient will have one of the following features. Okay, first one is it occurs at rest and it usually persists for more than 10 minutes. For stable angina, if you remember, for stable angina, I have said stable angina occurs after a certain amount of exertion or after a certain, emotional, at the height of emotion, the patient may develop stable angina. But in case of unstable angina or NSTEMI, it usually occurs at rest. And the duration is more than 10 minutes, whereas in case of stable angina, the duration was up to 5 minutes, 2 to 5 minutes most of the time. Second point, the chest pain or chest discomfort, it is relatively of recent onset. By recent onset, I mean it starts within the prior 2 weeks. And third point, it has a crescendo pattern. What do I mean by crescendo pattern? Crescendo pattern means there is increasing in severity, increasing in frequency, okay? So that means the chest pain which is coming, it will be more severe, it will be more prolonged, the duration will be more prolonged, the frequency will increase. That means more frequently the patient will start getting this type of chest pain. These three are the very important, or you can say a very clinching points, the suspect case of acute coronary syndrome. The discomfort, it is usually substernal or retrosternal, we can say, and there is usually radiation to up to the jaw. It can radiate in the upper back, it can radiate both the upper limbs, also the ulnar aspects of the forearm. Okay, and just to mention that it usually the pain never radiates above the jaw and below the umbilic. So there is a dictum. If the pain is below the umbilicus or if it is above the jaw, then we should, think of some other diagnosis. Other than chest pain, the patient may have anginal equivalence. What we say, anginal equivalence, which means other than chest pain, the patient may also present with severe dyspnea, shortness of breath. The patient may present with epigastric discomfort and nausea. These are also maybe the presenting features of a syndrome. And these inguinal equivalents are most commonly seen in female patients. Females or elderly patients, they usually present with this, atypical symptoms or inguinal equivalents. Coming to the sign. Now I have talked about symptoms. Coming to the sign means what we will get on examination of most of the examination finding is insignificant. Means we do not get much of the thing from examination. Okay? Sometimes the feature may be just like stable angina. I mean to say, on examination, there may be development of transient third or fourth heart sound. There may be mitral regurgitation features because of rupture of the capillary muscle, or there may be we may find it difficult to find the cardiac effect because of dyskinesia in the cardiac apex. So some of these signs, if noticed very carefully, we may get case of physical examination. If myocardial infarction involves a very large area, if there is massive myocyte necrosis, then some other associated findings will be diaphoresis, increased sweating in the patient. Okay, diaphoresis, the patient will look pale, the extremities will become cool, the patient may have sinus, cardia, third or fourth heart, I have mentioned. Basilar rail. Basilar rail, it is a sign of, cardiac failure or heart failure. So there may be signs of heart failure such as basilar rails or crepitations. Fine crepitations will be there. Sometimes there may be hypotension also. If most of the time, if there is involvement of the inferior wall along with the involvement of the right ventricle, usually tend to develop hypotension. Now, in this slide, I'm going to discuss about the evaluation points of a patient with suspected acute coronary syndrome. So what are the things we should take into account when we try to diagnose a patient of acute coronary syndrome? We need to concentrate on the presentation of the patient. What are the presenting features? Okay. We need to look for the ECG findings, and finally we should look for the cardiac biomarkers. That is most commonly done is troponin. Okay. So on presentation, if the patient says that I have chest pain and the patient can really pinpoint the chest pain, okay, and if on ECG it is normal and cardiac troponin is negative, most probably we are dealing with non-cardiac chest pain. Okay. Pain in the chest where the patient can really localize, can pinpoint the pain, or on examination if there is tenderness on that particular point, normal ECG and normal cardiac enzymes. Okay. That means the patient has non-cardiac chest pain. Otherwise, if the patient has chest pain, just now as I have described, substernal or retrosternal chest pain radiating to the neck, jaw, or radiating to the bilateral upper limb, upper back, along with some positive signs of ischemia in the ECG. For example, in case of NSTEMI, that is non-ST elevated MI, there will be ST depression. So in this ECG, you can see the ST segment. This is the ST segment. There is depression of the ST segment. Or in case of STEMI, there will be elevation of the ST segment. So this is the ST segment and this is the baseline. So there is elevation of the ST segment. Okay, so these are the ischemic findings from ECG. Along with this, there will be elevation of cardiac enzymes. If the patient has typical chest pain and ECG changes, but there is no cardiac enzymes elevation, then it will be a case of unstable angina. But if there is ST depression in the ECG and cardiac enzyme is positive, then it will be of NSTEMI. And if there is ST elevation like this and cardiac troponin will be elevated in a much higher level, then it is a case of STEMI. So this is how we can do the initial evaluation of a patient who Symptoms suggestive of acute coronary syndrome. Three things: presentation, ECG, and cardiac enzymes. ECG, just now I have seen. Coming to the investigation part, ECG, just now I have talked. There will be ST depression. There will be new and deep T inversion. A T inversion of 3 mm or more is significant. So ST depression along with new and deep T inversion of 3 mm, we should be looking for in the ECG. They are suspecting case of NSTEMI or unstable angina. Unstable angina patients, they may not have very typical ECG findings, and the ECG findings may be transient also. Cardiac biomarkers, I have said, this is a very important point again. If cardiac biomarkers are negative, then it is unstable angina. If it is positive, then it is NSTEMI. Okay. Now, third thing we will do is that stress testing. Okay, we will do a stress testing, and then we will see the how much workload the patient's heart can tolerate, and at what level patient develops ischemic symptoms or ischemic signs in their ECG. In equivocal cases, means where the diagnosis is in doubt, we can do a coronary angiogram, coronary computed tomographic angiogram, that is CT angiogram of coronary can be done if the diagnosis is in doubt, okay, to confirm our diagnosis. But most of the time from the clinical presentation, ECG and cardiac biomarkers, we can really diagnose a patient of stable angina or NSTEMI. This slide I'm going to come later on. Now, as I was talking about elevation of cardiac enzyme, just to mention that the myocardial infarction is not the only reason for elevation of cardiac enzyme. When we evaluate a patient, need to be careful on that point also. So what are the causes of elevation of cardiac enzyme or cardiac troponin specifically? Okay, cardiac causes may be there, or there may be non-cardiac causes as well. So in the cardiac causes, there may be tachyarrhythmias, congestive heart failure, hypertensive emergency, or myocardial diseases like myocarditis, pericarditis, okay, stress cardiomyopathy, which is also known as cardiomyopathy, or structural heart disease like aortic dissection, coronary spasm. Okay, after certain cardiac procedures also, that is also important. After a CABG, after a PCI, okay, even after CPR, many of the time CPR to a patient, okay, having cardiac arrest, going cardiac arrest. So in those patients also, if after doing CPR we do a blood analysis, the troponin level will be elevated. So these are the reasons for elevation of cardiac causes of elevation of troponin. There are certain non-cardiac causes as well. So what are the non-cardiac causes? We also need to remember these causes. Pulmonary embolism, one of the very important cause. Pulmonary embolism, the patient will be presenting in the same way like pain, breathing difficulty, tachypnea. The presentation is like an acute emergency. Pulmonary embolism or pulmonary hypertension, chest trauma. It may be because of blunt trauma, or maybe burn, or maybe case of electrical shock, hypo or hyperthyroidism, because of snake bite, okay, renal failure, again one of the clinically one of the very important cause, because if we are going to look for troponin in patient diagnosed to have CKD or chronic kidney disease, the troponin level will already be elevated in quality evaluation. Sepsis, shock, in those cases also cardiac troponin can be elevated. Stroke or other acute neurologic event, okay, extreme endurance effort, okay, rhabdomyolysis. So these are the non-cardiac causes of non-cardiac or systemic causes of elevation of cardiac troponin T. So just to mention that this is very important from your competitive exam point of view also, because you may be asked that the cause of elevation of cardiac troponin. Okay. Coming to the risk stratification, okay, it is very important. Why so? Because only after we stratify the risk, we do a triage depending on the risk factors the patient is having, then only we can do a proper management. Everybody does not need the same type of treatment. First of all, we evaluate the patient thoroughly, stratify the patient's, and depending on the risk level, maybe it may be a very high risk patient may be having. What risk we're talking about? The risk we're talking about is of the risk can be of death, the risk can be of recurrent coronary syndrome, myocardial infarction. So after risk stratification only, we will come to know who is having a very high risk of future cardiac event, who is at high risk of death because of cardiac problem, and then we can accordingly we can manage the patient. So in risk stratification, history very important, GPE, general physical examination, ECG findings, and cardiac biomarkers can be integrated into an estimate of the risk of a particular patient. Cardiac biomarkers, more the elevation, more the risk. More the elevation means more amount of myocardial necrosis, so the risk also will be more. So in the risk stratification, we have different scoring systems. That is also very important, not only just for your theory purpose, but it is also important for your competitive exams as well. We have three types of scoring system. Okay. TIMI risk score. What is TIMI? TIMI stands for thrombolysis in myocardial infarction. Okay, this is actually this risk score is attained from a trial named TIMI trial. TIMI risk score. The other risk score is HEART, HEART, HEART scoring system. HEART scoring. What does this HEART stands for? H stands for history, E stands for ECG, A stands for age, R stands for risk factors of CAD, okay, and then T stands for troponin. So this is again one of the scoring system where history, ECG, age, risk factors are given certain score ranging from 0 to 2, and then depending on the scoring system, the patient's risk can be stratified. That's how much risk the patient has. One more risk scoring system is there, that is GRACE. Okay. Global Registry for or Global Registry of Acute Coronary Events. So this you can remember, TIMI, HEART scoring, and GRACE scoring. These are used for the risk stratification of NSTEMI or unstable angina. Now coming to the TIMI score, how do you score a patient? That is again important. There are certain parameters in the TIMI risk score, and depending on the parameters, certain points or scores are given. So the points or the parameters are age, 65 or more, known coronary artery disease, coronary of more than 50%, 50 or more, ST deviation by more than 0.5 mm on presenting elevated cardiac marker, 2 or more episodes in prior 24 hours, prior angina, 3 or more CAD risk factors. So if the patient score is 0 or 1, there is 5% chance of adverse cardiac events. Adverse cardiac event, what do I mean by adverse cardiac events? Adverse cardiac events means the risk at 14 days of death, new or recurrent myocardial infarction, or severe recurrent ischemia, recurring urgent revascularization. These are the risks I'm talking about: of death, risk of new or recurrent myocardial infarction, or risk of severe recurrent ischemia resulting in urgent revascularization. So, as I said, if the score is or the point is 0 or 1, has 5% risk, and if the score is 6 or 7, patient has a risk of 41%. Okay, so this is how actually we stratify the risk of patient. by TIMI scoring system. Now, I have skipped one slide, that is heart coding. So this is the heart pathway for evaluation of, taken from the latest edition of, not there in the previous edition. So you can just look at it. It is very easy. How you evaluate a patient of chest pain, how you decide whether the patient or not. The patient with acute chest pain, definitely you do an ECG. In the ECG, if there is ST elevation in the ECG, you follow the protocol of management of elevated amount. If there is ischemic feature in the ECG, you do a troponin and then you observe the patient or you can admit the patient. If in ECG there is no ischemic changes, that means nothing on the ECG. On presentation, chest pain, you have done an ECG, nothing on the ECG. Patient is a known case of coronary artery disease. Then again, you do an initial troponin. If it is less than 99th percentile of the upper limit also, you observe or admit the. If there is no history of CAD, means the patient has come to you with chest pain, you have done an ECG, there is no ischemic changes in the ECG, and the patient has no history of prior CAD, then what you're going to do? Then comes the importance of heart score. So if the heart score is 0 to 3, you do measure the troponin serially. And if it is less than 99th percentile of the upper limit, you discharge the patient. Early discharge can be done. If it is 99 percentile or more than that of the upper limit, then patient will require a cardiology consultation or an admission. This is how you stratify. This is how you decide which patient is discharged early or which patient admitted into the ward or which patient requires cardiology consultation. Now, coming to the most important part from medicine point of view, that is the management. How do you manage it? Okay. We have learned how we can, diagnose a case of NSTEMI or unstable angina. So the last part is the management. How you can manage a patient. Definitely, we need to manage the patient properly. Otherwise, it may cost life of the patient. Such a disease it is. So, in the acute phase, what we are going to do, we will try to relieve the patient of symptoms and stabilization of the culprit lesion. That is important. In the acute phase, patient will come with chest pain, nausea, diaphoresis, okay, anxiety. In those cases, for those symptoms, we will give symptomatic treatment for the patient, and we will try to stabilize the culprit lesion, or we will try to stabilize the plaque. Long-term phase, what we're going to do for the long-term management, we will try to prevent the disease progression, and we will also try to manage the risk factors. Manage the risk factors of CAD. It is not that we only should manage the case, we should manage the acute presentation, but also need to the risk factors of the patient so that the patient do not develop any future cardiac events. Now, management approach for unstable angina or NSTEMI. What we do initially, when the patient present to you initially, what we do, okay, there are certain things which we should advise at the first medical contact. The patient should be advised for bed rest. Usually, if I talk about bed rest, usually we advise bed rest for about 6 to 12 hours. Why bed rest? Because the heart is already diseased. We don't want cardiac workload to increase. So if the patient is ambulatory, there will be increase in cardiac workload, which we don't want. That's why we will, almost enforce the patient to have bed rest for at least 6 to 12 hours. After that, the patient can be, advised for ambulation, slow ambulation. Continuous rhythm monitoring, very important. You have to be ready with the cardiac monitors, because a patient who has acute coronary syndrome, they are very prone to develop cardiac arrhythmias. More so about ventricular tachycardia, ventricular fibrillation. So we need to have a monitor for the continuous rhythm monitoring. Ready defibrillators. Definitely we have to have defibrillator by the side of the, because if there is arrhythmia in ventricular fibrillation or ventricular tachycardia, the patient will require immediate defibrillation. Otherwise, the patient will die. Moist oxygen. Okay, so oxygen is advisable for patients even if the saturation is normal. Also, we need to give oxygen for the patient to reduce the cardiac workload. So we can give oxygen at a rate of 2 to 4 liter per minute for at least for 6 to 12 hours we can give. And what are the medications we should be starting? Anti-ischemic agents. So among the anti-ischemic agents, we have nitrates, we have beta blockers. Then second group is antiplatelet agents. The antiplatelet agents will give aspirin, clopidogrel, and GP2B3A inhibitors. Okay, usually we give dual antiplatelet therapy. DAPT stands for dual antiplatelet therapy. So we give aspirin along with clopidogrel. And sometimes the patient requires triple antiplatelet therapy. The patient requires triple antiplatelet therapy. Then we will add this GP2B3. GP2B3 usually added, okay, in the antiplatelet regimen when the patient requires PCI or when the patient develops recurrent myocardial infarction on dual antiplatelet agent. That means the patient was on dual antiplatelet again. Over that patient develops myocardial ischemia, then we need to give a third agent, that is GP. I said before doing PCI, we need to give this. Why we need to? Why we don't give always? Because it causes bleeding. It has a high risk of bleeding. That is why we do not do this all the time. Anticoagulants. So among the anticoagulants, we have intravenous anticoagulants, or we can give oral agents also. Unfractionated heparin, low molecular weight heparin can be among the oral agents, factor Xa inhibitor and direct thrombin. So these are the group of drugs which we will be giving to a patient of NSTEMI or unstable angina. Anti-ischemic agents, antiplatelet agents, anticoagulants. This is the medical management of a patient of NSTEMI. Emergency unit, what we usually do. As I said, the patient will be kept in the bed for bed rest, oxygen will be given, we will keep the cardiac monitor ready, we have the defibrillators ready, and then start with different medications. Just to mention that, you can remember the emergency management with this mnemonic, MONA. So M stands for morphine. Okay, morphine. O stands for oxygen. N stands for nitrate. A stands for aspirin. So these are something which we can never forget. Okay? So morphine for reduction of the pain, oxygen as I have already mentioned, nitrate as an anti-ischemic measurement, first choice as an measurement, okay, and also the first choice as an antiplatelet. So in short, you can remember as MONA. This is just for easy remembering. Now, coming to the nitrates, we can usually start giving sublingual nitrate. We can give 3 doses of sublingual nitrates, 5 to 10 minutes apart, as an anti-ischemic measure. That means patient chest pain, for the patient chest pain, we will give sublingual nitrates 3 times, 5 to 10 minutes apart. After nitrates, beta blocker can be added or initiate early for ischemic symptoms. Beta blocker is also something heart rate, reduces arterial pressure, it reduces cardiac workload, and in this way it helps in reducing the chest pain. The blocker can be given. I have already talked about the contraindications of blocker in the class when about the treatment of angina. So I'm not going to go into the detail of it. Calcium channel blockers. Okay? Calcium channel blockers can be used as an anti-ischemic measurement, but uh, calcium channel blockers are usually given if the patient is not tolerating beta blockers or if the patient has contraindication for the use of beta blockers. Usually, we do not use beta blockers and calcium channel. I was talking about morphine. Morphine should be given as an basically as an analgesic we use because the patient have severe chest pain. Opioids like morphine. Morphine can be given if the patient is not responding to sublingual nitroglycerin. Doses of sublingual nitroglycerin, patient's chest pain is not coming down, then we can give morphine. Morphine we can give at a dose of 2 to 4 milligram IV. About morphine. So morphine we can give at a dose of 2 to 4 milligram IV, and we can keep on repeating for 3 times if the patient is not responding with the initial doses. Contraindication of morphine: if there is hypotension, okay, we cannot use morphine. Morphine may cause respiratory depression and or obtundration. While using morphine, we need to be careful about it. As I said, morphine to be used if there is continued angina, even despite 3 sublingual nitrogen. About morphine, this is what we do in the emergency ward after the first medical contact with the patient. Now, coming to the anti-platelet therapy, okay, as I have said, we have oral antiplatelet aspirin, drug of choice, and the first drug we use as a platelet agent. So, initial dose of aspirin is given as loading dose, 325 milligram loading dose, and it should be followed by a dose of 75 to 160 every day. Aspirin can be combined with clopidogrel. Clopidogrel is a T2Y12 inhibitor. So clopidogrel can be combined with aspirin. Clopidogrel is also given at a loading dose of 300 to 600 milligram, and it is followed by 75 milligram per day. Mention that aspirin and clopidogrel is usually combined. So we usually in acute cases, acute coronary, prefer to give dual antiplatelet therapy, that is aspirin combined with clopidogrel, and it is advisable to continue this dual antiplatelet therapy for at least 12 months, which can be followed by indefinite use of aspirin. Different authors or different books will have different opinion regarding the dual antiplatelet. The books, standard books, you find that they say that combination of aspirin and clopidogrel should be continued for a period of 1 year, and after that clopidogrel can be stopped and can be continued indefinitely. Clinical practice, we usually advise aspirin for lifelong. Prasugrel and ticagrelor. Prasugrel and ticagrelor are also the same group of drug, that is Y12. These two drugs, prasugrel and ticagrelor, they are usually used as to undergo PCI. So before PCI, loading dose is given, and after PCI also it is continued, ticagrelor and prasugrel, these two drugs. They are not usually used, means instead of clopidogrel we could have used prasugrel or ticagrelor, but because they have a high risk of bleeding. So that is why the preferred therapy with dual antiplatelet agent is aspirin and clopidogrel. Yes, clopidogrel. Intravenous antiplatelet therapy, GP2B3A inhibitor, as I said, they are apixaban, aptifibatide, tirofiban, and cangrelor. Apixaban, aptifibatide, tirofiban, and cangrelor. At your stage, you can just remember the names. Closing is a bit difficult to remember, I'll say, but please try to remember. It'll be helpful definitely. I will not go into the detail of the dosing. Okay, you can go through the book and you can really read about the dosing. Anticoagulants. Anticoagulants, as I have said, anticoagulants, again, we have parenteral anticoagulant and have oral anticoagulants also. So in acute stage, we prefer the parenteral anticoagulant like unfractionated heparin, low molecular weight heparin, or fondaparinol. These are the preferred agents. So unfractionated heparin can be given as a bolus dose of 70 to 100 units per kg, followed by infusion. Okay, the bolus dose should be followed by an infusion of 12 to 15 kg per hour. Enoxaparin is also a preferred drug. We in clinical practice we use enoxaparin or fondaparinol. Enoxaparin is usually given at a dose of 1 milligram per kg 12 hourly. Remember that. It is easy to remember the dosing of it. 1 milligram per kg subcutaneously twice daily. But if the patient has renal insufficiency and the GFR is below 30, once daily dose. 1 milligram per kg once daily if creatinine clearance is less than 10. When you give enoxaparin, when you start, first we can give an IV bolus of enoxaparin of 30 milligram. After giving 30 milligram IV bolus, then we can start with subcutaneous dose of 1 milligram per kg 12 hourly. Fondaparinol, again the dosing is very easy, 2.5 milligrams per day. Once daily dosing, 2.5 milligrams. Bivalirudin, these are the parenteral anticoagulants used in patient of acute coronary syndrome. Oral anticoagulants. So what are the oral anticoagulants we can use? We can use vitamin K antagonists like warfarin can be used. Okay. Apixaban, dabigatran, direct thrombin inhibitor, endoxaban, rivaroxaban. So you can just remember the name of these agents. They are the oral anticoagulant agent, novel oral anticoagulant. They are known NOAC and means novel oral anticoagulant. Novel oral anticoagulants like apixaban, rivaroxaban, endoxaban, dabigatran. These can be used in a patient of coronary syndrome, acute coronary syndrome. Okay, after GP2B3 inhibitor, as I said, we don't use this drug so commonly. We don't use this for every patient. Use for patients intermediate or high risk, where the ST is depressed, raised troponin. That means it is ischemic, okay? And it is usually used in patients with diabetes. Patient should be maintained on the same drug during and after PI, and it is always combined with coagulant. Whenever we give GP2B3, should be combined with oral anticoagulant. Anticoagulants, okay, how long we need to continue anticoagulant, that is important. For antiplatelet, I have said. Now, duration of use of anticoagulants, how long we use. Anticoagulants can be stopped in 24 hours after an invasive procedure. Anticoagulants can be stopped in 24 hours after an invasive procedure, maintained up to hospital discharge in a conservative strategy. So that means if the patient has undergone an invasive procedure, that means within 24 hours of the invasive procedure, it can be stopped. Or if the patient has not undergone any invasive procedure, it can be maintained up to the discharge from the hospital. Or sometimes we say that it can be given up to 7 days. 7 days of the starting, or it can be timing of hospital discharge. Conservative strategy. When we advise for conservative strategy, it is recommended in patients with no recurrence of chest pain, no signs of heart failure, no abnormalities in the initial or second ECG. That means within 6 to 12 hours, there is no abnormality in the ECG. No elevations of troponins. That means on arrival also there is no elevation, and 6 to 12 hours later also there is no elevation of troponin. So that is important. When we really need to know when we advise a patient for invasive strategy, when we advise a patient for conservative strategy. Conservative strategy for NST, ACS is advised when there is no recurrence of chest pain, no sign of heart failure, there is no ischemic changes in the first ECG and in the serial ECGs after 6 hours, and there is no elevation of troponin at arrival and on serial measurement of troponin at 6 to 12 hours. These are the conditions when we, when we manage the patient with conservative treatment. We do not advise the patient to undergo a PCI. Now, when we advise for invasive strategy, when we need to say the patient that you have to undergo a PCI. Following initiation of anti-ischemic and anti-thrombotic agents, coronary arteriography is carried out within 48 hours of presentation. So, within 48 hours of presentation, we need to do a PCI for NSTEMI. And if the finding is suggestive of high risk, then we need to advise the patient for revascularization, coronary revascularization, only for high risk patients. But for low risk patients, suppose we have done a coronary angio after 48 hours of, and there is a low risk for the patient or low coronary thrombus load, in that case the outcome from an invasive strategy and the outcome of a conservative strategy is almost same. It is comparable, or it is, again I'll say, because many times there is confusion that when should the patient, when we should advise the patient for revascularization, for coronary stenting or CABG. If we have done a coronary angio and we found that the patient a high risk group, patient is in high risk, patient has high load of coronary thrombus, occlusion is too much, in that case we'll advise for revascularization. Low risk, if the patient has low risk of future events, coronary events, or low risk of death, then in that case the the treatment strategy for invasive and conservative, the outcome will be similar. There is no difference. Do a conservative management, also be doing good. That is about the revascularization. Now, how you select the treatment strategy for revascularization, how you select it, this actually depends on the risk stratification, I have said. So, after symptoms, the patient will present to hospital or the emergency medical team go to the patient. So, after the first medical contact, the diagnosis of any case will be. If the patient is presenting to a PCI center, there can be two scenarios. The patient is presenting to a center where PCI is available, and the patient is presenting to a center where a PCI is not available. So if suppose the PCI is available in the particular and the patient has a very high risk, okay, high risk for future cardiac events, then the immediate invasive strategy should be done, that is less than 2 hours. If the risk is high, then early invasive strategy should be done less than 24 hours. And if the risk is intermediate, then invasive strategy can be done up to 72 hours also. So very high risk should be done within 2 hours. High risk should be done within 24 hours. Intermediate risk, it should be done within it should be done within 72 hours. Now, if the patient is presenting to a non-PCI capable center, and if the risk is very high, then patient immediately transferred to a center where PCI is available. High risk, same day transfer. Remember these things. Very high risk, immediate transfer to a PCI capable center. High risk, same day transfer. Intermediate fluid transfer and make sure that the PCI is done within 72 hours of presentation. If the risk is low, then non-invasive strategy is appropriate. Okay? So very low risk, you can go ahead with the conservative strategy. Okay? Revascularization may not be necessary. So once you do an angiography of the coronary artery, you find that anatomy suitable for revascularization. What you do? If it is a single vessel disease, you advise for a PCI. Then coronary stenting you advise for. And if it is involving the left main vessel or multi-vessel disease, then the preferred choice is CABG, that is coronary artery bypass graft. There has always been confusion that which one is better, whether PCI is better or CABG is better, or which one you should be advising to, when you should be advising, or when you should advise a patient. Right? These are important. So small single vessel disease advice for PCI, multi-vessel disease or left main disease advice for CABG. If the anatomy is not suitable for revascularization, then you consider for unconventional. There are certain unconventional well or treatment which are under trial. And medical therapy should be continued definitely after PCI, even after CABG should be continued, and the patient should be assessed for stress testing periodically. Be assessed. Now, what is advisable, PCI or CABG? As I have said, the left main vessel or multi-vessel disease advice for single vessel disease, not left main, to advise for PCI. So, what are the disadvantages of PCI? Major disadvantage is there may be redevelopment of angina, and the patient may require repeat coronary angiography and repeat revascularization. Higher with PCI. There may be stenosis in the stented segment, but again it has come down with the use of drug-eluting. New stenosis in the unstented region. It will, the PCI, in the PCI, the stenting will be done only in the culprit lesion. But the future lesions, what about the future lesions? The lesions, again, there may be stenosis. It focuses only on culprit lesion. Stroke rates are lower with PCI. This is an advantage over CABG. This is an advantage. CABG, there is high risk of development of stroke, which is lower with PCI. We talk about CABG. The bypass graft to the target vessel and also provides fluid around future culprit. How? See, this is a culprit lesion. Okay, here it was the culprit lesion, resulting in stenosis of the coronary. Now, a stenting is done in the present lesion. But look very carefully. Here is a future culprit lesion. Future, there may be a complete occlusion of the coronary in this area. But with stenting, this area is not covered. It is left behind. It is not covered. And in future, there may be a need for revascularization. But if you do a CABG, we can even bypass the future culprit lesion. Okay, this is the graft used. This is the present lesion and this is the future lesion. So with the help of a grafting, bypass graft, we can avoid the future culprit lesion as well. But the only thing is that CABG is associated with a risk of stroke, whereas PCI has very lower risk of development. In short about PCI and CABG. I was talking if the anatomy is not suitable for revascularization, conventional style can be. One of them is hence external counterpulsation. Just remember the name, external counter, where pneumatic caps are placed on the lower extremity. What does it do? It decreases cardiac work and oxygen consumption. That much you can remember. Conventional treatment, it uses a pneumatic cap in the lower extremities and it reduces the cardiac workload and oxygen consumption. Long-term prevention. It is very important. It is not that we will just treat the immediate symptoms or immediate presentation and we will leave the patient like that. No, we have to think of the long-term safety of the patient. Very much prone to develop future cardiac events. So risk factor modification is very important. I have already talked about the risk factors. So risk factors should be modified. Statins and ACE inhibitors, they do play a very important role because they they help in improving the endothelial dysfunction. They also help in stabilization of plaque. Very important. Statin improves endothelial dysfunction, stabilization of the plaque. It does. ACE also does the same. ACE inhibitors also prevents the cardiac remodel. For that, beta blockers to be continued as a long-term treatment, and antiplatelet, as I have said, aspirin and clopidogrel to be continued for long term for around 1 year, dual antiplatelet followed by aspirin for indefinite period. There are some studies or trials which shows that SGLT2 inhibitor is SGLT2 inhibitor, that is sodium glucose co-transporter 2 inhibitor, can also be used in case of this group of patients. Basically, this is an anti-diabetic developed as a diabetic medication, but in different trials, it is found that it good cardiac beneficial. This can also be used the long-term treatment. Now, this was all about unstable angina and NSTEMI, non-ST elevated MI and unstable angina. I have talked about clinical features. Then I have talked about the diagnosis, everything. Now, a little bit about asymptomatic ischemia. It's also a very important thing. Asymptomatic ischemia. As the name suggests, the patient will not have any symptoms, but the patient will be having ischemia, the myocardium. Actually, there is no clear-cut consensus, so no clear-cut guideline about the management. Actually, found if we are doing a routine investigations, it can be diagnosed with the help of stress testing. When we do stress testing, can be diagnosed, or it can be diagnosed with cardiac MRI, cardiac PET scan. Okay? And the management, once we know that the patient is symptomatic, okay, we need to treat the patient definitely. So the treatment actually depends on the age of the patient, occupation of the patient, severity of his everything. So suppose, just for example, I am saying, suppose a young male, suppose a 45-year-old male pilot and having a symptom, we need treat the patient and we need to advise for, even if the patient needs, we need to advise for revascularization itself. Management of risk factors very important. All the risk factors for CAD should be modified, should be managed. Beta blockers, statins, and aspirin can be advised because they the mortality, okay, reduces the future cardiac events in this group of people. So beta blockers, statins, and aspirin. If there is triple vessel disease on coronary injury, definitely. So we need to know about this also, that there is something known as asymptomatic ischemia or silent ischemia. Coming to the Prince metal angina or variant angina. This is again an important area we need to know. It is important for your competitive exam point of view also and practical. What happens in Prince metal angina? Prince metal angina has severe chest pain which occurs at rest. Typically, it occurs at rest. So remember about stable angina, it occurs in case of exertion. A fixed amount of exertion will result in stable angina. But in Prince metal angina, it is at rest. There is no relation with effort. And why it happens? It happens due to spasm of the coronary artery. Vascular spasm. It is a vasospastic. If spasm of the epicardial, big coronary artery results in lack of blood supply to the particular area, resulting in variant or Prinzmetal angina. Some of these patients do have a generalized vasospasm disorder, okay? Maybe associated with migraine or Raynaud's. I will talk about this when I will talk about Raynaud's class life session. The patients are usually younger. What is the patient profile? They are usually younger. They have very less or very few coronary risk factors. The patient will be coming presenting their chest pain. Okay, the chest pain is like stable angina, but it occurs at rest. At rest, no relation with comfort. The patient is young, evaluate or when very few risk of coronary events or coronary artery. So why it happens? It happens because of increased contractility of coronary smooth muscle. The vascular wall, there is smooth muscles, increased contractility of the smooth muscle in response to certain certain stimulators like adrenergic vasoconstrictions or serotonin. These results in spasm leading to Prinzmetal angina. There is transmural ischemia, okay? And there will be, because of ischemia, there will be abnormal LV function. LV function, left ventricle function, and sometimes it may be so severe, the Prinzmetal angina may be so severe that may lead to acute myocardial infarction, may lead to ventricular tachycardia, lead to ventricular fibrillation, or SVT stands for sudden cardiac death. So it can have varied presentation, and the only thing is that when you are coronary, because someone is presenting chest pain, just like stable angina, but at rest, when you evaluate the patient, when you do a coronary angiogram, okay, typically the coronary angiogram will be normal. There will be no occlusion, there will be no thrombotic plaque in the artery. Then you should be suspecting of Prinzmetal angina. So how we diagnose? If the coronary angiogram is normal, how we can diagnose of patient? ECG changes. There will be transient ST elevation with chest. There is ongoing chest pain, do an ECG, there will be transient. Angiography will be normal. Okay? Angiography will be normal. There will be no obstructive lesion in the angiography. Okay? There will be abnormal left ventricular function. But when you do a vascular reactivity test or vascular function test, how do you do it? You give intracoronary acetylcholine, provided there is no obstructive. When you give intracoronary acetylcholine, there will be focal spasm. There will be vasospasm. Provokes focal coronary stenosis on angiography. Or it can provoke rest angina with. You do a normal angiography, there is nothing in the coronary. But when you coronary acetylcholine and you do an angiography, you see that there is focal spasm in the coronary, epicardial coronary arteries, or there is development of rest angina with the diagnostic point, okay, or this is the diagnostic modality for the Prinzmetal angina. How do you manage a case of Prinzmetal? Okay. Nitrates can be given as an anti-ischemic measure. It is not so much helpful, but somewhat it is. Calcium channel blocker, and in the long-term management, statins given. If along with the vasospasm, if the patient has discrete lesion, coronary thrombus occluding the coronary lumen, then the PCI and CVG will be advised. If patient is prone for ventricular fibrillation, then ICD to be advised. Implantable cardioverter defibrillator. Implantable cardioverter related fibrillator. You will hear about this term when I talk about cardiac arrhythmia. So ventricular fibrillation, prone to ventricular fibrillation, you advise for an ICD, inflatable cardioverter defibrillator. Very importantly, never give aspirin to this group of people. That is why making diagnosis, when you are certain about diagnosis of metal angina, you should never give aspirin, because when you give aspirin, it may even increase the symptoms of the patient, because when you give aspirin, there is changes in the synthesis of prostacyclin, and even a little bit changes of prostacyclin synthesis will result in increased coronary spasm. So aspirin will increase the coronary spasm, resulting in these symptoms. So no aspirin, no aspirin in others. They have said you can. So this is about the metal angina. Lastly, a little bit about microvascular angina. Till now, what I was talking about was all about the epicardial coronary artery or macrovascular. Now, a little bit about microvascular angina. What is microvascular angina? Microvascular angina means involvement of the smaller coronary, where the diameter of the heart, sorry, diameter of the coronary artery less than 400 micrometer. Up to 400 micrometer, they are epicardial coronary. After that, when it is below, the diameter is below 400, they are microvessels, microcoronary. They may be pre-arterial, arterial, and capillary. So, pre-arterial, very well. These are very small arteries. Microvascular angina is also known as cardiac syndrome X. There is involvement of smaller coronary vessel, as I have said. Symptoms of angina, microvascular angina, the name is angina. There will be symptoms, but there will be no myocardial disease, no obstructive lesion when you do an angiogram. The syndrome can be primary, microvascular angina can be a disease itself, or it can be associated, or it can be secondary to obstructive coronary artery disease. So the classification is primary or it may be secondary. So the important points are there will be no myocardial disease, no obstructive lesion on angiogram, but the patient will have ischemia, microvascular angina. Again, the normal coronary angiogram will be normal because there is no obstruction in the coronaries. Okay? And very importantly, there should be no spasm on acetylcholine challenge, which we have used for the diagnosis of Prinzmetal angina. In intracoronary, there was spasm. But in this case, when you give intracoronary acetylcholine, there should be spasm. Stress testing is important. It can be diagnosed with stress testing. Cardiac scintigraphy, okay, SPECT or PET scan can be done to diagnose the ischemia in the myocardium, and vascular function test. So these are the diagnostic. So the diagnostic test for microvascular angina. Why I am discussing this topic? Many times, many of the patients have microvascular, they have recurrent chest, but we miss the diagnosis. Why so? Because when we do a coronary angio, there is nothing. When you do an intracoronary acetylcholine test, there is no spasm. We will think that maybe it is a case of non-cardiac chest, but no, we should be evaluating to this test, cardiac MRI, stress test, PET scan, vascular function test, diagnose so that we can treat the patient. So microvascular angina also very important. Discuss management of microvascular angina. Of course, lifestyle modification is very important. Modify the risk factors, exercise training, and medications. Medications are same like antiplatelet agent. You have beta blockers, platelet, beta blockers, statin. These are the important drugs which we should be continuing for long term, and we should do periodic and definitely nitrates and enriched can be used. So this is all about microvascular angina. So if I talk about the treatment algorithm, if the patient has presented with chest pain, we need to talk about the symptoms. Symptoms are stable, then we need to do stress testing. With unstable symptom, we cannot do stress testing. The symptoms are stable, we need to do stress testing. Okay. If the stress testing is normal, on stress testing everything is normal, then we need to we need to evaluate about non-cardiac chest pain. Have done stress testing, no findings, then non-cardiac causes of chest pain should be evaluated. If you have done a stress test and it is abnormal, then you go ahead with a coronary. Symptoms unstable, then you also go ahead with coronary angio. Coronary angiogram is normal angiography or non-obstructive CAD. Angiography is normal, non-obstructive CAD, then you consider for vascular. Okay, if vascular study, function study is also normal, that means again you evaluate for cardiac. If vascular function study is abnormal, then you give aggressive management, okay, medical and symptomatic management for microvascular angina. So aspirin, beta blockers, statin, AC inhibitors, tricyclic antidepressant, treatment. These are the management protocol for microvascular. And if the angiography is not normal, with the patient, or the patient needs vascular revision or the conservative strategy sufficient for the patient. Just remember, for microvascular angina, angiography will be normal. Acetylcholine test will be challenge will be normal. Okay, only the stress testing will be. This is how you can diagnose microvascular angina, and you can that patient not develop future cardiac events. So this was the end of this class. I hope you have enjoyed the class. If you have any queries or anything, you can just ask me. I'm here to clear all the doubts. Previous class also, I really got good response from you, and I hope that you will continue watching the classes. Be beneficial for you, I hope, and I pray. Anything, any query want to ask? These are really very important topic, and if we don't know these topics properly, lose lives, because ultimately we have to treat the patient. This is our ultimate aim, that we can lives. These topics are very emergency medical situations where we really need to know, not panic. We really need to know what we should do. Any query? Ask. Anything you want to ask? I'm here to clear your doubts, and who want to ask later also, you